Hi, my name is Connie McClarness and you're watching the video 6 Cranial Nerve Palsy, Clinical Characteristics. In this video, we will discuss what to expect when we have a lateral rectus palsy in terms of the ocular motility assessment. Okay, so with a lateral rectus palsy or a sixth nerve palsy, we expect that there will be an esotropia in primary position. Recall that the ipsilateral antagonist, the medial rectus, will have contraction, will be overacting and will be unopposed, and as such the eye will be esotropic. If it's recently acquired, as you already know, the primary deviation will be smaller than the secondary deviation. What we haven't discussed is that the esotropia will also be larger in the distance, regardless of whether it's recent or has been there for a while. The reason it's larger in the distance is because the lateral recti are required to diverge the eyes out in the distance. And given that you actually have a palsy of the lateral rectus, there is a limitation in the eye's ability to achieve this, and as such, the esotropia will be larger in the distance as compared to near. This is a hallmark sign, or very characteristic of the sixth nerve palsy, where you see an esotropia that becomes larger in the distance. You should always suspect the sixth nerve and look very closely at the lateral rectus, because generally, in most instances, an esotropia will be larger at near with accommodation and vergence increase. Okay, the other obvious characteristic will be that the ET will be larger in lateral gaze. So if you have a right lateral rectus, it'll be larger in right gaze where the lateral rectus acts, and then if you have a left lateral rectus palsy, it'll be larger in left gaze. Of course, if it's long-standing, it becomes more concomitant. The incompetency between positions of gaze will alter, and we'll see similarity between, say, for instance, primary right gaze and left gaze. In terms of ocular motility, be aware of your muscle sequelae. If you have a lateral rectus palsy of the left eye, the medial rectus of the ipsilateral eye will be overacting, and then we'll also get the contralateral antagonist will be overacting, and we'll get secondary inhibition of the right lateral rectus or the contralateral antagonist. As I mentioned in some previous videos, you need to look out for contracture of the medial rectus. Contracture of the medial rectus with long-standing palsies can actually hide the amount of lateral rectus ability. So if you have a tight medial rectus, the issue will occur that as the patient tries to abduct, the tight medial rectus will be holding it back. Again, remember, mechanical restrictions have their effect or create limited movement in the opposite position of gaze. So the medial rectus being tight will cause greater problems in abduction. So as an example, if we have the right medial rectus tight or contracted, then the patient will have difficulties looking out into right gaze, and you may interpret that as a lateral rectus -4 as an example. Now, it could actually be a lateral rectus -3 or 2, but the tight muscle is not allowing you to see the full capacity of that lateral rectus. So this is where, for instance, Botoxing the medial rectus will give you a better indicator of the lateral rectus function, or you need to do a force duction test and have a look at that medial rectus and see if it's tight and causing you issues in terms of your assessment of the lateral rectus. Okay, to the right here we have a patient with a lateral rectus palsy, and you can see from the bruising on her face that she's actually had a lateral rectus palsy from trauma, which is a relatively uncommon cause for a sixth nerve palsy. But we can see that in primary position here, she has a left esotropia. When she looks over to right gaze, we have a reduction in that esotropia, and she looks relatively aligned in the photograph. And then if she looks over to left gaze, we can see that we have the limitation in abduction, and here we have a larger esotropia. So in terms of her area of BSV, we're aware that we'll have diplopia here, as we have a manifest deviation in primary. Diplopia in this position of gaze, there'll be greater separation of the images here. And if she is actually aligned in this position, she may actually have single vision. If she's still slightly esotropic in that position, then she will have diplopia, but those images will be closer together. Okay, I want to discuss one other feature of the lateral rectus palsy, and specifically in relation to your assessment of actually the superior rectus and inferior rectus. So here we have a patient with a right lateral rectus palsy, and in primary position we can see the right esotropia. And as the patient looks over to the right, we notice this -4 lateral rectus minus. Now, as the patient attempts to move up, we can still see that there is limited abduction here. So, and when she looks down, I should say, and here as well, we can actually see still this -4 abduction. If you want to assess the patient's inferior rectus, which you need to get them to the right and down, or their superior rectus, where you need to get them out and up, your issue is that the patient actually has limited capacity to abduct. And so your ability to look at the superior rectus and the inferior rectus is inhibited by the lack of abduction. Now, because of this, you also need to be aware that where we have the greatest diplopia will be in right gaze in this instance, and not just where the lateral rectus acts, but right gaze overall, both here in up gaze, here in right gaze, and here in down gaze, so dextroversion, dextroelevation, and dextrodepression. The patient will have diplopia in all these positions because dextroelevation and dextrodepression also require the patient's capacity to abduct, and this is not occurring here. The Hess chart. Now we can see what we just discussed in the patient in the photograph is occurring here in the Hess chart. We see here we have a patient with a right lateral rectus palsy, and the lateral rectus is underacting here, and it affects the entire right gaze. The superior rectus, whilst we're not able to get the patient into this position, is relatively okay. This is where the patient put their light when you were asking them to look into dextroelevation, and it's relatively in the right position. It's slightly over here, but not significantly so. And here as well, we see that the inferior rectus is okay. Actually, this indicates here that we have slightly more limited abduction as the patient tried to come into down gaze. We also, in this particular Hess chart, see the overaction of the contralateral synergist here. And in this photograph, we can see the primary deviation is the right eye with the left eye fixing, and here we have the secondary deviation, which is greater. In terms of the rest of the muscle sequelae, we're not seeing any obvious change here to the left lateral rectus, and the right medial rectus here is potentially we're not seeing much overaction here either. We've got in primary position, if we have a look here, we've got a 5-7 degree ET, and here we have just under a 5 degree ET. In relation to the diplopia, you'll have generally just horizontal diplopia, given that you've only affected a horizontal extraocular muscle. So we expect horizontal displacement, and again we expect that the displacement comes across the entire right gaze. You may see some differences between these three positions, but in this particular instance, they're all around 3 centimetres apart. And again, depending on whether you have a right or a left lateral rectus palsy, the greatest deviation will be in the position where the lateral rectus is acting, or the affected lateral rectus acts. In terms of area of BSV, we'll obviously have an area of BSV in the position opposite to the field of action of the extraocular muscle that's affected, and here in this particular example here, this is right side, this is left side, we have BSV on the left side here, which means we must have a right lateral rectus palsy in this particular instance. And again, just as I mentioned earlier, we've affected the entire right gaze, and the patient also has diplopia in prime position, and about, 7 degrees into left gaze, the patient still has some diplopia, but soon after that regains BSV. So in terms of the head posture, obviously the head posture for 6 nerve palsies is a head turn. We don't see chin ups, chin downs, and tilts in these patients. You may see chin ups, chin downs if there's an associated alphabet pattern, but in most instances there aren't alphabet patterns. But do be warned that if you do have an alphabet pattern, you could see more than just a head turn. Okay, so again, the head turn will be to get the patient's eyes into the position of gaze where there is single vision. This child here, we can see they've got a LET in primary position. We can see here limited left abduction. We can see a greater esotropia in this position. And as we move the patient over into right gaze, we can see alignment in this position. So the patient is using a turn left to get their eyes into right gaze. And you can see this is a position where the patient gains BSV. We can see that they're not fully abducting here or fully adducting. So the patient doesn't need to be in full right gaze to achieve BSV. They can do so several degrees out of primary position. Moving on now to bilateral sixth nerve palsies, you can have a patient who has both abducent nerves affected. In this instance, you will or should see a marked angle of deviation. Having both lateral rectus affected will give you a marked angle of deviation. We can see this in this patient here. She has a very large esotropia in primary position. So we should see limited abduction of both eyes. Here we have limited abduction of the left eye and limited abduction of the right eye. And the right eye abduction is more affected than the left eye. So the right eye has been affected more so than the left. Now these patients will generally have diplopia in all positions of gaze. And if you choose to occlude them to regain single vision, not binocular, but single vision, then often they will display a head turn. And we can see with this patient here, she's wearing a pair of glasses and she's been occluded on the left side. And what she's done is she's moved her head to the right because of the issue she has with the bilateral defect. It assists her to gain foveal fixation. So in these instances, when you've occluded the patient presents with an abnormal head posture. It's not for the purposes of BSV, obviously, you've occluded them. It's so that they can gain better foveal fixation, given the bilateral defect that they have. Please also be aware that you can have a congenital sixth nerve palsy. Now, these are relatively uncommon. They will display the characteristics of a sixth nerve palsy. So you will see a esotropia in prime position, as we see here in the image to the right, and obviously you'll see a lateral rectus under action in these particular instances. Now the causes are varied. They can be birth trauma, there could be maternal infection, and there could even be a developmental issue where the lateral rectus hasn't developed normally, and also a hereditary impact. There may be a family history of a sixth nerve palsy. However, they're relatively uncommon, and what you can see as you look at this child is they look exactly as an infantile ET would. So we'll come to differentiating between a sixth nerve palsy or congenital sixth and infantile ET, but more commonly this sort of patient is an infantile ET, but you need to rule out that it's a sixth nerve congenital palsy. Okay, so in summary, a sixth nerve palsy will give you an ET in primary position. The deviation will be larger in the distances compared to near, and obviously it'll be greatest in lateral gaze depending on whether you've got a right or lateral rectus palsy. And with concomitancy, this will start to settle down, and you will see that the deviation or the esotropia will be similar across the three distances, the three positions, primary, right and left gaze, if it becomes concomitant. Okay, so on ocular movements, expect that lateral rectus under action, but again, don't forget to look out for medial rectus contracture or a tight medial rectus if you have a long-standing patient that's masking the action of the lateral rectus. In terms of diplopia, it'll be horizontal, it'll be uncrossed, and it'll be greatest in the lateral gaze, and therefore your area of BSV will also be in lateral gaze, so you'll only need a head turn, right or left, depending on whether you've got a right or left lateral rectus palsy. And don't forget, you can also have a bilateral or a congenital sixth nerve palsy. For bilateral sixths, you will have lateral rectus minus on both eyes, and you'll also have a marked esotropia in primary position. Okay, and finally with the congenitals, they're relatively uncommon, but they will present at birth with an ET in primary position and a lateral rectus under action. Okay, that brings us to the conclusion of this video. Thank you for watching.